Hello everyone, my name is Jakub Batycki. I'm a dentist. I done my postgrad diploma in oral surgery. I also done a postgrad advanced diploma in dental implantology in the University of Salford. Currently I'm doing my PhD in periodontics at Medical University of Wrocław. Today I wanted to show you my recent studies, and this presentation introduced to those studies and show the results of them. For the purpose of this presentation, I use my own microscope illustration module on AI, so no royalties there. So let's start without further ado. The presentation will introduce you to osteoimmunology and foreign body response. That's the theoretical foundation for the further research. We will go through the volume as a marker of osteoimmunology, and then we'll have some clinical cases. So starting from volume as a marker of osteoimmunology. The osteoimmunology is extremely complex science that is constantly evolving. So what was updated a couple months ago may not be relevant now. So we have to constantly update our knowledge, so it's a never-ending story. Here, but every story has to start somewhere. So we'll start in bone morphogenic unit. That's all what we remember sometimes, and it consists of 3 types of cells. Osteoclasts that are bone resorbing cell, osteoblasts that are bone forming cells, and osteocytes. Those cells they produce something called the bone remodeling cycle, where part of the bone is resorbed, then there is a transition zone where the osteoclasts are fading out and the new cells appear. That's what we always thought, that the different mediators guide the change. What we know now, so this transition zone is occupied by 2 types of cell. That was the traditional view. Now we know that this is it's a multi-cellular event, including multiple immune cells, and most importantly, some stem cells like MSCs, and some transition cells, which are not osteoclasts and not osteoblasts. We call them transition cells. We know that as well that the speed or longitudinal erosional rate is directly influenced by the osteoprogenital cell recruitment rate. Going forward, we will shift from the classic view into more precise view. To start it, we'll introduce you to the bone forming cells. So you got the osteoblast and osteocytes. They both derive from the mesenchymal stem cell, or more precisely mesenchymal stroma cell. These are main reservoirs of osteoprogenital cells. They are primary connective tissue cells that can derive into multiple lineages. They usually reside in bone marrow, but they are also quite numerous in adipose tissue, as well as the perivascular space known as a pericytes, cambium layer of periodontium as a bone lining cells, as in periodontal ligaments, in dental pulp, and in endosteum bone lining cells. So these cells, these tissues are known as a reserve of osteoprogenital cells. The number of cells is directly proportional to the vascular density. That's another very important trope. So such a cell, mesenchymal stem cell, can derive into osteoblast, but also it can actually maturate into chondrocyte, it can maturate into adipocytes, so the main free lineages. But also it can actually change into way more cells, depending on the cocktail of mediators it's exposed to and then transcription factors. So they can basically change into multiple different tissue cells. As you can see in the following research, then the scientists are working on changing MSCs into different cells to be able to regenerate and work with disease. From our perspective, the most important transition is between the mesenchymal stem cell and fibroblast, osteoblast, and adipocyte. Most common transition is a lipogenic differentiation, which is way more common in osteoporotic patients, or osteogenic differentiation. As an implantologist, we want the latter one. So to guide MSC into osteogenic differentiation, we need higher concentration of bone morphogenic protein 2. We need higher oxygen concentration. We need a higher cell density. We need a higher medium density. We need a proper mitochondrial activity. What helps to guide it? Calcium phosphates, normooxia or hyperoxia, or TGF beta, high concentration. So anti-inflammatory environment. The other type of the transformation is between osteoblast and fibroblast. And from the research, what we got is, again, one morphogenic protein 2, high concentration, higher cell density, higher matrix density, and low mobility will guide the mesenchymal stem cells into osteoblast. High mobility, presence of mechanotransduction, exposure to certain factor, colon-only transforming GF, will transform MSC into fibroblast. And as it progresses, it may even transfer into myofibroblast, and this transformation is irreversible. To make the story even more complex, in this study, the authors took the MSCs from the same tissue of 4 different patients and found out that there are completely different biomarkers, and they are primed to turn into different tissue depending on your metabolism and your genetic background. So such as MSC turn into pro-osteocytes and then into osteocytes. As you can see, as the osteocytes produce more and more bone, we are getting actually formation of osteocytes, and the osteocytes, we didn't know much about them, but what we know now is that they form about 42 billion cells that are connected together with about 23 trillion dendritic connection. They are able to actually regulate phosphate and calcium level. They regulate the muscle formation, adipose tissue formation, and the function of nervous system. So we know that osteocytes can actually influence the function of MSCs. So osteoclasts are another cells. These are completely different creatures. They are syncytial, which means polynuclear, high metabolic cells that works more or less like a spice harvester in dunes. They work only for a short period of time, which is another similarity. Those cells derive from hematopoietic stem cells that occupy hematopoietic niche, which is usually surrounded by MSCs. So those two cells interplay between each other. So such a hematopoietic stem cell will modify into common myeloid cell, then into promonocytes and the monocytes. Monocytes are in the circulating blood for a relatively short period of time. Then they will reach the tissue where, depending on the mediator they expose, they can change into osteal macrophages when they are exposed to macrophage colony stimulating factor, or into osteoclast once they are also additionally exposed to rank. So monocytes have a very short half-life, about 24 hours. So our body creates a reserve of them in the spleen and also in the gut-associated lymphoid tissue. And these are usually like a pro-inflammatory monocytes. They are ready for action whenever needed. So those cells are waiting to be transferred into this healing site. Then in the tissue, so like in a bone, we got additional population of immunomacrophages. They divide into M1 macrophages or M2. The M1 are slightly more inflammatory, M2, so they resolving, they're usually used in a very first stage of healing, and M2 are more hemostatic. At the same time, we know that part of the population of osteal macrophages derive from embryonic tissue, like a yolk sac or fetal liver. So such an osteoclast have very short lifespan, and it derives from the fusion of osteomorphs, macrophages, and monocytes, influenced by a rank that is secreted by MSCs, neutrophils, T cells, and B cells, depending on the stimulation. Following the short onset of action, without further stimulation, the mitochondria will not last too long, because it really takes a lot of energy, and the mitophagy will trigger the fission that will break this polynuclear into small single-cellular, single-nucleated osteomorphs. The problem starts once we start using some medication like denosumab, which blocks ranks, and that way it increases osteomorphs. So the moment we start the patient withdrawn from taking denosumab, there could be a massive surge of osteoclastic activity. Also, we know that OPG mediator is actually bonding to rank and stopping it, and this is all regulated by our immune cells. Going forward, we can see slowly that the landscape is developing. We know as well that macrophages influence macrophages M1 activating osteoclast, or they can create a fusion. From the hematopoietic stem cells, we have we got a megakaryocytes and the blood platelets that produce a lot of very important factors that are useful in first stage of healing. We also have a B cells, T cells, and the antigen presenting cells, such as dendritic cells, which is also a very important population to have an influence on the bone healing. So this is the landscape of the osteoimmunology. Interactions or malfunction of those cells can influence the outcomes, or medication and influence that. We need to be aware of that, because the bone healing is not simply the mechanical action, it's more of the immunological reaction. And all those cells will eventually take part in the foreign body response. So that's the landscape. From the recent Nature study, we know that the first 2 weeks we got a mainly fibroblast and myeloid cells, and then the involvement of lymphoid tissue goes up after 4 weeks. So from 2 weeks to 4 weeks we got this surge of the lymphoid cells and the further transformation. So in osteoimmunology, the foreign body response can be divided into early, intermediate, late, and then later matrix maturation. It can also be divided into acute phase, subacute phase, and late phase. No matter how we divide it, it consists of the certain stages. So just wanted to show you how works FBR and at which second what you expect or minutes. So the first seconds or minutes of FBR, we got the protein adhesion. We want to have a hydrophobic proteins. The hydrophobic medium attracts more proteins, and more proteins such as vitronectin, fibronectin attracts aggregation of the plates. Also, the high content of calcium can attract other type of specific proteins such as osteocalcin and collagen, and it can also activate the complement. So we know that following the protein adhesion we will have a platelets aggregation. Platelets aggregate relatively quickly, and they produce a lot of factors that are extremely important in healing, such as TGF-beta, vascular endothelial factor, epidermal growth factor, or platelet-derived growth factor. Those factors and the number of platelets is influenced by calcium. So calcium induce and increase the production of aggregation of proteins and also p-selectin. So after the aggregation of platelets, we have a special formation called blood-based provisional matrix, which looks like a net that grabs all the tissue and more of these factors and more of the p-selectin. We got more BMP exposed. We will have more adhesion of the next cells, which are neutrophils. So you see this net grab the neutrophils, and they also and as the neutrophils are on the spot, they start to activate complement, which is the bridge between innate and adaptive immune response. You can see the speed and ferocity of neutrophil accumulation in the following video. They're forming something called neutrophil extracellular traps, called nets, and they try to phagocyte the object, the foreign body. We call it a frustrated phagocytosis, and as the result, as it's frustrated, it's a massive stress on those cells. They release reactive oxygen species, they release NOx, they release MMP9 and MMP8. Neutrophils are released in a circadian fashion, and more neutrophils you got in the morning than evening. So neutrophils, as they produce lots of reactive oxygen species, they commit apoptosis, and that cells attracts monocytes, which are guided by necrotaxis to dissolve neutrophils. So we call it a find me signal. And as the neutrophils monocyte replacement happens, and just so you know, where are the neutrophils, where are the monocytes, the cousins. So neutrophils, the replacement happens between first and second day, and here is very important story. So during this replacement phase, there are very potent mediators. If we have macrophage colony stimulating factor and interleukin 10 and tumor growth factor beta, we will have more of lymphocytes T2, and we will get slowly into this non-inflammatory mode. Contrary to that, if we got TNF alpha, interleukin 1 beta, so pro-inflammatory interleukins, we will have transformation into pro-inflammatory macrophage M1, which produce rank, which is activator of osteoclasts. So as we know now, initially the macrophages will always differentiate initially into M1. We cannot avoid it, we can minimalize it. Why? Because we always have a little bit of LPS from the bacteria. We always will have some reactive oxygen species and nitric oxide. This polarization can be altered by the mesenchymal stem cells and by compounds such as calcium or sulfates. We know that from the other research, but we know that it modifies this type of the response. So the window of opportunity happens between 5th and 7th day. It's when usually the macrophages that are mostly pro-inflammatory will switch into more chemostatic M2 phenotype, and that's a very important moment in healing, because depends on that we can have two distinguished outcomes. One will guide us to long, chronic, low-grade inflammation that leads to fibroepithelialization, and the other to resolvement and then new tissue formation. So the mode of action, if we have a lot of neutrophils, if the tissue accumulates a lot of platelets and proteins, then we'll have a lot of neutrophils, then we have a lot of monocytes that destroy the neutrophils. The population of monocytes then turn into the population of pro-inflammatory macrophages, and this high operation, very intense operation, will most likely resolve the inflammation in the tissue, following the drop of population of macrophages M1 and then a growth of new population of macrophages, chemostatic macrophages M2. Chronic high-grade inflammation can lead to the prolonged pro-inflammatory phenotype that will lead us to chronic fibroencapsulation. So what we need in order to achieve the good outcome? We need definitely macrophages M2, which are guided by interleukin 10, TGF-beta, arginase, or interleukin 4. We need a lot of MSCs. We need a lot of calcium in the medium. We need fibroblasts as well and osteocytes. Definitely bone morphogenic protein 2 and oxygen level, so lots of blood vessels. If we want to achieve that, if we have a lot of LPS, low oxygen level, mobility, inflammation, the macrophages won't change into M2 and they will remain inflamed. Such as macrophages won't form giant cells, or will less likely form giant cells, and if they do, those giant cells, those polynuclear cells, will be osteoclasts. Also, fibroblasts will go and change into myofibroblasts. So how to modify it? That's a good question. We know that high calcium and phosphate availability in the and stabilized matrix promotes macrophages M2. So how to modify this body response? Oh well, we got one thing which definitely works throughout the whole foreign body response, which is biphasic calcium sulfate and beta TCP. We know that they both work sequentially, that match and they match body healing timeline more or less. So you can see that calcium sulfate works through early to intermediate FBR, and beta TCP works from intermediate toward matrix maturation. So how it works? So calcium sulfate is hydrophobic, so it attracts more proteins, and it also attracts calcium mediated absorption of vitronectin, fibronectin, osteoclast, and collagen 1. We know that calcium serotonin guided platelet interaction, we got a little bit more platelets when we have a calcium sulfate. We know that it prevents excessive oxidative stress, increase the vascular density, reduce NETs, and increase bone morphogenic protein 2, which are very important factors. Beta TCP is the matrix, it stabilizes the extracellular matrix, so it's more rigid, more dense. It provides constant and long-term relief of calcium phosphate ions that in turn increase the recruitment of stroma cell and angiogenesis. It modifies ECM. It guides the macrophages into M2 polarization through the calcium-induced channels. It increases the oxygenation of the tissue perfusion, and it also recruits the Tregs, which are hemostatic T cells. And on the long run, they through the macrophages that are M2, they induce formation of giant cell tissue giant cells that are managing extracellular matrix and guides the formation of the bone. So we got some information about EthOss works from all the articles. We know that calcium sulfate works within the first 4-6 weeks mostly, and beta TCP works a bit later, but it lasts for a very long time. We don't precisely know how long it lasts, but some studies say 9 to 12 months. So how to screen the foreign body response? So far we got 4 ways. So we can do the bit of the pre-screening preparation of the patients by saliva testing or blood testing, making sure the patient is prepared for the surgery. We can screen early FBR by pain monitoring. We can do a trepine biopsy, and we got quite a few studies of that. That in any given time, following the placement of EthOss or implant, and see what's happened around it. Or we can do volume screening. So pain monitoring will give us an idea on the 2nd to the 7th day, will give us an idea where we are with healing. So the high pain yields the presence of pro-inflammatory markers and show us that the more of the M1 macrophages, and lower pain means chemesthesia, means more M2 macrophages. That's one way. The volume screening is quite interesting concept that I will guide you through. So providing that we're not doing any x-rays or anything, we just screen the volume by checking the STL or what have you, to see what's there. So if we got the volume maintenance or the volume gain, we know that this volume of tissue around implant is not it's not just gingival thickness, it's also the bone underneath. We know it from the research that assess that the tissue volume equals the gingival thickness and the bone we know that correlation is 0.7. So with the growth of the volume, gingival and the bone components grows. Based on this assumption, idea of doing scan of the tissue before the surgery, after surgery, and long-term after surgery will give us idea what's happened underneath and how the biomaterial guides the healing of extracellular matrix and further matrix maturation. So pre-procedure scan and post-procedure scan, comparison of them will give us an idea what's happening early to intermediate FBR. Post-procedure to long-term outcome will give us an idea how it works intermediate FBR and matrix maturation. Comparison of them. So very well done. Let's go into clinical cases. So the inclusion criteria for this study was that EthOss has to be used and no tissue graft, so no CTGs, just purely an implant and the EthOss. The chosen cases were based on clinical performance data, where we've seen that maxillary premolars, anterior maxilla, and mandibular molars are most commonly placed implant. Starting from anterior maxilla, we got 5 cases. We've got late, delayed, immediate inflamed socket shielding, and immediate no inflammation. Firstly, the late case, we have long missing tooth, atrophic bone, some aesthetic complications in the front with malposition of the frenulum. Here, the digital planning was done, and also some soft tissue planning to handle the position of frenulum. We've got the temporary bridge placement just to see where we want to see the implant. We've got placement of implant. Is the inverter implant. Then we place and torque the implant. You can see the position. We got the first layer of EthOss applied. We left it for about 5 minutes, and then the second layer was applied. Then it was left for, I call it a creeping attachment technique. We wanted to see whether it works, and the crown was applied. So that's healing after 7 weeks. That's healing on a 14 week. And then we've got 6 months post-fit. And then we got 12 months post-fit, so you can see the tissue stability. So taking all this information together, I just wanted to show you the x-ray, so you can see the normal bone formation around this area. We've got 4 scans, and we wanted to compare them. So what's the best way to compare them? Is firstly to align them properly, as precisely as possible. And that way we got a metadata click that is very well aligned. We then combine those data together and push it through the programming software called Slicer 3D in the model-to-model distance. And then we have those leaders. So the way to picture them, the best way would be a heat map. So we have a heat map generated that shows us how much of the tissue we gain on every stage. So the first initial stage, we've got quite a lot of tissue gain, about 2.33 millimeters in the center, with some mild growth around the area. From 4 months to 6 months, we've got mild bone level, growth, possibly stabilization, And then we got stabilization with a little bit of the growth, a little bit of remodeling, but nothing too serious comparing to the previous one. Then you can see the volume analysis. We got increase in the volume, then we have stabilization and the further increase later. Another case, we got 2 broken centrals, completely broken, unrestorable. Even the best endodontist wouldn't be able to fix those. We remove those two roots, we clean the socket, degranulate it, and put EthOss inside. We put the temporary 3D printed bridge. Following 3 months, the implants were placed. They were tissue level implants, so the precision of placement was extremely important to achieve the papilla position and all other factors. After 3 months, the implants were scanned and the crowns were produced. Then we have a crown that after a short period of time was loose because the tissue pressure was very high and maybe my torque wasn't strong enough. Then patient disappeared and this came back 4 years later and got photos, x-rays from the first month before. 4 years after, sorry. So that's what we got. We got two photos showing the normal bone formation, and we've got scans. Let's compare them. We line those scans together. We make a heat maps, and what we can see, the initial following the extraction, we have resorption in the coronal part with maintenance of the volume. So you can see the volume is maintained. Of course, there was inflammation, so there was a bit of resorption. Then what we see, the stabilization of the tissue. So about 4 months after placement, after removal and graft, we have full stabilization and a little build. And then from scan, so 4 months to 4 years later, we have a lot of increase. Not a lot, but there's enough to see it, and it's ranging from 1.5 millimeter to 1 millimeter or 0.8. And that's what we got. You can see the protocol, and that this material works on the long run. Another case, immediate implant placement into inflamed socket, so we got the internal resorption. Even best endodontists wouldn't be able to fix it. The tooth has been removed and socket cleaned. We place an implant. And we grafted it with EthOss. We fit the jump gap with EthOss and put temporary crown. That's alright, and you can see the healing, and you can see on the left the infection, and as the infection slowly resolves, 4 months later there was something, but way less. You can also see the bone level is well supported. You can see that, yeah. So then we got 3 scans in the time points of pre-operation scan 4 months and 18 months after placement. All right, so here we have scans, and you can see the bone, the tissue resorption in the first stage, where we have quite a lot of inflammation, followed by tissue stabilization with a little bit of formation. And you see on the 28 months there was still tissue there and quite well restored. Another case, this is the case of socket shielding. We have 2 teeth and the patient decided to just restore it with single implant. So in order to maintain the volume, we decided to use a socket shielding technique. So the teeth were The restoration was planned for a large single implant. The teeth were decoronated and the shield was left and cleaned, you can see, and then we place an implant into the designated area. It was a coaxial inverter implant. We place an implant and tighten it. We place EthOss and temporary dwarf crown to keep it safe. So that's what we got. Got scans. We've got fit, initial fit. We've got 6 months review. And we've got 12 months review. So that's what we have. It's the overview. You can see the x-rays. And we got scans. So let's see what's happened. So with the socket shielding, we have way less bone resorption initially, followed by very mild bone resorption later. So indeed, it limits resorption of the bone, the socket shielding. Okay, another case. Here is the immediate placement in the area where there is low inflammation. So you can see the fractured crown, but not much of the inflammation. Here is highly aesthetic zone with no lateral incisors. It's a cantilever bridge. So the teeth was removed, area cleaned, degranulated, and the implant was placed. As you can see, we placed an implant, we grafted some EthOss, and we restored it with a temporary crown. We then scanned the side. And place the crown. 12 months later, here we have x-rays. We got STLs. Overlapping those STLs, we will see heat maps. So you have a low, very low resorption comparing to the inflamed side, followed by the increase of the tissue from the scan 4 months to 12 months. That's what we got from the pre-op to scan, and from the scan to month we got some increase of tissue. The next part is maxillary premolars. We got 3 cases here. We got a late case, we got immediate case, and we got immediate placement and load. So the late case is quite complex because we have a very low sinus level, so we needed to do internal sinus lift and some buccal remodeling to create a nicer situation. So there was a bit of planning. The papilla spearing flap was prepared, implants were placed. The socket, the sinus was lifted, and the EthOss was placed on the buccal side to accommodate around soft tissues. We've got EthOss applied, and we have a flap beautifully placed. We then suture and let it heal for 4 weeks, 3 months. We've got finally scans and fit of the crowns. And as you can see, a little bit of margin was exposed. And then it's a photography 6 months post fit, which is 9 months post placement. And then we got 12 months post fit and 15 months post placement. You can see the gum has attachment has go up where the gum has gone up. So that's what we got. We got 3 scans and we want to see what's happened. Sorry. Want to see what's happened. So we can see the increase of the tissue growth on the initial phase, but most importantly, later on we have a beautiful increase of the tissue after between the 4 and 12 months. Then we have an immediate placement where we remove premolar and place an implant immediately. So here we have a fracture inflamed premolar. We remove this tooth, expose a bit of the bone and place a very large diameter tissue level implant. We put some EthOss and we put a little bit more EthOss buccally. We put some sutures and achieve a very good healing. That's 7 days after. Then we got 3.5 months scan. We've got fit. We've got 9 months review. So taking these time points, preoperative scan and 9 months, we've got 3 scans. We overlap those scans and we have a little bit of the decrease of the tissue where the tooth was removed, but very little and definitely not much of the weight loss. We've increased around the implant. That is followed by general increase on the tissue volume. And here we're talking about very little volume decrease. Then we have this infected bridge. There was a fracture and infection. You can see fistula in the channel. We use tissue level implants with a changeable angle. So it's a coaxis technique. We remove the teeth. We clean the socket. We put a temporary clip-in bridge as a primitive guide. Place the implants with coaxis and make sure that they are quite parallel and not touching other teeth, so it was quite difficult navigation to have a perfect position. And then we have a fit, and following the fit, we clean the site again. Then we have scans, 4 months, 6 months, and then we got 12 months. So let's see how the volume looks. This is the X-ray. We've got 2 sites of inflammation shown, 4 months, 6 months, and 12 months. We've got 4 scans. And what can we see? Pre-procedure to 4 months, we got a little bit of resorption, but only where there was infection. Then it's followed by the further later resorption around the tooth that wasn't replaced with implant. So it was a long missing pontic, but mainly the tissue maintenance, very little loss. And then we have further stabilization from 6 months to 12 months. So that's what we see. Well done, you went through the premolar area and now the molars. Here I wanted to wrap it up and show you the late, immediate delayed procedure and immediate procedure for very similar teeth. They are lower 6s. So the first one is the completely fractured post-root canal therapy molar. This molar was then removed and the EthOss was grafted into the socket. Following the healing period, the site was opened, the implant was placed. It was very wide tissue level implant. We then done a modified roll flap and suture it over. Amazing. Then we have healing here. Very good. Then we have x-rays to show the healing. And we got 4 scans. We align those scans together, and what we can see, nearly no loss of the width. We got some coronal changes, alteration related to the presence of the infection in the first stage. Then it's followed by the rebound and the formation of the new tissue around the implant with a minimal loss of width, very little, 0.3. And then the long term, we've got the tissue increase and stabilization. Then we have immediate placement. So tooth was infected and fractured, unrestorable. We managed to remove that tooth atraumatically. Very good. And so you can see the scans, you can see the forcation, the moment, you can see the fracture. Okay, so the tooth was sectioned, removed atraumatically, socket was cleaned, debridement was done. We clean the site, place an implant, but before I always put some soft mix into the socket, then I place implant, then I top it up. Okay, once it's topped up, I remove healing cap and I put temporary crown or the healing abutment. That's another photos of healing. We've got the more recent photos for scans. We've got the fit of the crown. And 12 months later. So that's what we got. So these are our time points, and we got 4 scans. So let's see what we got. So obviously, as we could now possibly expect, whenever we got a high inflammation, there will be resorption initially. It's not a large resorption, but it goes around even 2 millimeters. Then it's followed by the process of stabilization, so there's no resorption anymore. The tissue stabilization is there. And then we got this late stage where we got slight tissue formation. It happens after 6 and 12 months. So that's what we got. I'm going back to our conclusion. So what is volume screening? It screened the gingival thickness and the thickness of the underlying bone. It allows us to check what's happened between early FBR and matrix maturation. In the first scans, what we see, we got quite different data. Some data shows the increase of the level of the tissue, some decrease, and it depends upon the type of the procedure. So the late cases, they have some bone and tissue increase. Immediate cases got decrease really, and post extraction also have a decrease, but not much of the width of the process is not disrupted. We got immediate cases where we got mixed case, and the late cases where we got increase. So if we divide immediate cases into the one with high inflammation versus the one with low, we can see that the one with low inflammation have very little resorption to nothing. So going further, so after 3 months to 6 to 9 months, we have intermittent FBR, and in that stage we don't have much of the resorption. The resorption is very minimal, maximum is 0.1, and only in a particular cases, but mostly we got stabilization. So if we divide into cases, they do not differ too much. Even that early, there is already the tissue stabilization, and in a very late stage, so it is immediate, everything between 9 and more than a year, we have consistent tissue growth, and that's most interesting finding. I don't know why it happens, but I hope you enjoyed this lecture, and thank you very much for your attention. Thank you. I think we recorded some questions, but from what I remember, there was a question: why do we need to know osteoimmunology? No, well, it's as it develops, it can foster our approach, and we have to constantly adapt to the changing knowledge, especially when it benefits us. Yeah. So here the using of EthOss and knowing osteoimmunology definitely help you to restore problem faster. It also allow you to predict what's happened. So you know what to do and you know what's happened. So it's very useful. Thank you very much.